Good Tuesday afternoon to everyone. TJ Alls, I-45 now and Galveston now, along with Dr. Philip Keiser, the local health authority for Galveston County, as well as the chair of the, I should say, the director. What is your title actually with the health district now? I'm losing track of it now. CEO of the CEO of the health district, and also infectious disease expert at UTMB Health. As I said last week when you joined us, 25 different hats. And again, we're back on our regular weekly show now, talking about mainly most things with COVID and how are things going there. And I was looking at the numbers that were released today, Dr. Keiser, and at one point we had more than 100 people in the hospital affected with COVID-19, more than likely Omicron variant there. It's now down to 59 active cases that are hospitalized. And looking at the numbers there, are we at a point now where we've seen maybe a peak of COVID-19 as it relates to the Omicron variant right now?
Yeah, I think we are. I think we probably reached that peak about a week and a half ago, maybe about 10 days ago. And the numbers have been steadily going down. And that's a really good thing. We've also seen the hospitalizations drop off a little bit. We are seeing more deaths, but all of that's to be expected. So, we're looked a lot at what happened in South Africa with the Omicron virus, because it came and very quickly and then it went very quickly. And what they've seen there and what we're seeing in the United States as well is that as it peaks, the hospitalizations probably peak about 2 weeks later and the deaths probably peak about 3 weeks later. So I wouldn't be surprised if we continue to still see fairly high numbers of hospitalization for the next week or two, and also continue to have people dying from their illness over the next 2 to 3 weeks.
And right now we're looking at the positive cases by city, and the active cases in Galveston County, 13,139. As I said, though, at this point, 59 folks are in the hospital in there. So it's still, as we have talked about several times, COVID-19 is still spreading, at a point of levels that we hadn't seen since one of the latest, the surge that happened with Delta. But as you look ahead to February, do we see a lull there, or do we see something else come right behind it? I know some folks were catching on to something of there's a variant of the Omicron variant, or a different version of Omicron variant that's out there. Can you talk about that some too?
Yeah, so there's this new variant called they're calling it Omicron Plus, or the other Omicron, or the Omicron variant. We don't know a whole lot about it yet, but thus far the people that study these viruses in detail seem to think that it doesn't represent enough of a change to be a real threat. And that's probably true. We saw the same thing with Delta. Remember, we saw Delta, then we saw Delta Plus, and there was Lambda, which looked a lot like Delta, but that didn't really affect us. And then Omicron came out of the blue. So, the way things are going, if the numbers continue to decline the way they are, and we continue to follow the pattern that South Africa had, and also the pattern that they've had in the United Kingdom, we can expect things to bottom out sometime in mid to late February. But that doesn't preclude something new coming along. And so with Omicron, so many more people are being infected that, one of the benefits of this is that there is going to be a lot more people with some sort of immunity out there. And I think the Omicron virus might burn itself out to the point where it's just circulating at low levels. And then we have to wait and see whether something else happens, And if we're looking at mid to late February, well, what happens then? Well, that's when Mardi Gras season hits, right? And so we'll see after Mardi Gras, we see another big surge.
And on that, have we actually seen as of late? We had the holidays and the surge came from there, but have we seen any of these kind of big gathering events? What we referred to as super spreader at one point as being a major threat to the spread here, or has it been just the normal, folks going to the grocery store? Where is that? Because I don't know how much contact tracing is going on now. It's
pretty much impossible to do a detailed contact tracing with the numbers that we're turning in. And so with Delta, we were definitely able to find cases where there were super spreader events. The church camp, right? And some of the scientists at UTMB, Dr. Scott Weaver, did very detailed analysis of the virus than that, and showed that that was a super spreader event. You had a bunch of kids, and one of them had COVID, and a week later, almost 200 of them had COVID.
Right.
Omicron, in some ways, though, is different. It is so infectious. It's to me, it's even getting to the point where I'm amazed that people are escaping it, because we're seeing people that have been vaccinated get it. We're seeing people that have had it before, had COVID before, getting it. We're seeing people that have had COVID before and been vaccinated and getting it. And I'm running into people more and more who have had, this is their second episode of COVID, and it's primarily Omicron. We know it's 100% Omicron at this point. We get analysis every few days looking at the numbers of cases, and it's 100% Omicron. And this just spreads so much more easily and so much faster. I'm not sure that this whole idea of a super spreader is applicable anymore.
And that's why I was asking, because one, because folks are also taking different steps where they're these events. I've noticed that folks have kind of taken on to themselves of, maybe not being as close to folks. Now it's, we were talking about Mardi Gras. That's going to be a little different than what most of the things have gone to. But for example, I'll be going to a lot of chamber events this weekend, throughout the weekend and this weekend, and where, folks are going to be in close proximity to one another. But even at that, folks are kind of keeping their distance, and, some are still wearing masks and the like. Yeah. They seem to be taking some procedures and protocols in place to protect them as best they can, which kind of really goes to the next thing I was going to ask you about is, and we talked some about this last week. I read an interesting article with the Galveston County Daily News this past week, is that in vaccinations, as testing has gone up, vaccinations though are at a stagnant level. Yep. There's not a high demand for the vaccinations at this point, and I think the term was used, we've hit a wall. So if the reality is this, is that, getting any percentage of the population vaccinated on something of any course is a tough one. Is that, what do we do instead?
Yeah, it's a really good question. So we vaccinated as many people as we possibly can, and I think last week we may have actually only vaccinated about 100 or so people, which is the lowest that we've ever done. It seems like many of the measures that that we had taken in the past, such as limiting gatherings and requiring people to wear masks, well, the public is just not putting up with that anymore, and they're not going to do it. Individuals are doing things, but for people that are concerned, I think the best thing to do is to limit your exposure, make sure you've gotten all 3 shots, because we've seen that for people that have gotten all 3 shots, the number of hospitalizations is virtually nothing. And so that's really the best way to protect yourself. And then the next best thing is to wear a mask. There are plenty of masks available. Don't wear a homemade mask like we all wore, about 2 years ago. Get a surgical mask, and you can actually get a free N95 mask from any one of the major pharmacy chains right now. And that'll be another way that you can help protect yourself.
You brought this up when we had Dr. Janet Patel on with you and I last week for UTMB Healthcare on Mass, talking about those N95s. They are a struggle to kind of breathe through. What do you recommend? Is the regular surgical mask just as good? I won't say just as good, but is it?
Yeah, it's so these are levels of protection, right? And so how comfortable do you feel, and how much do you want to wear something? The best thing is a fit tested N95 mask. So what that means is that you get a mask, it has to fit well on your face, and then they stick you in a booth and see whether there are any leaks around it. That's what they do for healthcare workers. And there are certain types of masks that certain people can wear and other people can't. And if you have a small jaw, well, you can't wear a mask that's fitted for someone like me. And I've even had some of my colleagues who have done the COVID wards who've shaved their beards, because having a full beard makes it so it doesn't fit well. The next thing would be a KN95 mask, and that's the kind of thing that you can get from the drugstore. And typically these are masks that have 2 tight rubber bands around them. But again, we just caution people, particularly people with respiratory diseases, try it out, because you may find it's so hard for you to breathe that it's not a workable solution. And in that case, then a surgical mask or 2 surgical masks on top of each other would be the next best thing.
But the cloth mask probably not recommended any longer.
Cloth mask probably not recommended. Or if you're going to wear a cloth mask, wear a surgical mask underneath of it.
Right, they had the double layer from that.
Yeah. Uh-huh.
This is a question we talked about last week, but I thought we'd bring it up early on. Rhonda Coburn asked, in January, there were 11 fully vaccinated deaths and 10 unvaccinated deaths. I'm not sure if that's exactly the numbers, but that's pretty close for the count to be.
Right.
How can this be? What is happening? Am I the only one that questions it? We talked about this, that there's two factors here is that many of the deaths are folks who have underlying conditions, and we're talking about severe underlying conditions.
Yep.
And so the vaccines will help some of those, but not all of those. Can we talk about that some? Because I wanted, we talked about this last week when we had healthcare and masks on, and I think more and more folks are kind of asking about this to understand that vaccines are not the end all be all to stop everything. Right. They help, but it's not the end all be all.
Yeah, they're really good. So if you think of these in terms of fractions. I know a lot of people don't like to do that, but if you've had let's just say that I don't have these figures right off the top of my head right now, but let's just say for the sake of argument, these deaths numbers are right. So 11 out of 250,000 people that were vaccinated, all right, and that's 10 out of about 90,000 people that were not vaccinated. Okay, the risk of not being vaccinated is much, much higher. The other thing is when you look at those reports, look at what we report. We can only report so much because we've got to be careful about identifying people and right. out people. But look at them, and you won't find a single one of them who is not having a lot of complicating factors. And there are people that we well know simply don't respond well to the vaccine. Among them, people that are elderly, people that have cancers and other immune suppressive diseases. And so to address that, there's just been released an antibody called Evishield. And this is something that you don't get it when you get COVID. It's not to treat the COVID to keep you from getting sick. It's actually designed to keep you from getting COVID if you're one of those people who don't make antibodies. So in that particular case, you would get your antibody infusion, once a month, and we've got it. It's in stock, and we're ready to give people. And it's something that should be decided in consultation with your doctor. And so we have some criteria, but we want people to talk to their doctors and ask, is this something that would benefit me, or am I going to be okay?
I'm glad you brought up the term infusions here too. A couple of things to clarify on this too is that this week the feds had said that there's 2 of the 3 available monoclonal antibody infusions. They say they don't recommend right now because almost all the cases are Omicron. Can you talk about that? Because monoclonal antibodies, particularly, we know Governor Abbott, when he had come down with COVID with a breakthrough case, got that done right away. He had no ill effects from either the shot, by the way, from the vaccine, or the monoclonal antibodies, or COVID itself. But can you talk about what the recommendation is and why it is that 2 are no and 1 is yes at this point?
Yeah. So think of monoclonal antibodies. These are designer antibodies that are made specifically for the virus. They're if you get a hearing aid, for example, you can get it molded to your ear. If you get, if you have a tailor-made suit, it's molded specifically to your body. So these antibodies were designed specifically to attack, a very specific part of the COVID virus. All right. So imagine now that the virus is mutated. So some of these don't fit anymore. I have a friend of mine who's a former Army officer, and at UTMB's graduation ceremony a few years ago, he swore in some of the graduates who were going into the military, and he wore his academic robes. I said, "You should have worn your uniform," and he goes, "It doesn't fit anymore." You see, and that's exactly what happened with these monoclonal antibodies. They don't fit anymore. And so there's only one that still fits, and that's the one called Tropimab. And we have not been using that since November 18th, I think, is the day we stopped using it. And that's because we were aware that Omicron was here and that we have not been using the ones that don't work. We've only
Right.
been using
Okay.
Popup since we knew Omicron was here. So we got a lot of these old antibodies. They're sitting on the shelf and they haven't been useful to anyone. We haven't been using them, and I think what the FDA did was simply make it official that you should not be using them. And then the state also said, don't even ask us for it. We're not going to ship it to you. So we still have the one that works. We've been getting small shipments of it. And so, for a while there, when we were having numbers really high over Christmas, we were worried we were going to run out. And so we had to tighten up the criteria on whom to give it to. But we've been able to hold out, and we still have some, and we're still actively giving it to people.
Is there a case if someone wants to get an infusion that and I say infusion, it's not, is this also available where you can do the whole 4-shot routine, or is it also only
this one requires an infusion?
Okay.
Yeah. So
if someone want to get infusion, is there a criteria they have to meet now to qualify for that because of the supply issue right now?
Right. So the criteria are pretty simple. You have to have COVID. You have to and have a positive test. You have to have symptoms, so you got to feel bad enough to go to your doctor, and then there's a whole screening criteria where the NIH has come out with tiers, and what we do is we basically say we're doing tier 1 and we're doing tier 2, and those are the 2 highest tiers. And so for the most part, most people that are vaccinated, fully vaccinated, probably wouldn't qualify unless they had some other underlying condition. But we also make exceptions. I get calls every other day from the nurses who do the screening, and they say, well, I got this guy, doesn't quite fit. I have this person, doesn't quite fit. What should we do? And so when that happens, we always try to err on the side of treatment and give people the benefit of the doubt.
And I've asked this before, this specific infusion is still monoclonal antibody that's available. Is that an mRNA design, or is it something else?
No, it's actually an antibody itself.
Actual antibody.
Yeah, but they're made by they're made with similar they're manufactured with similar types of technology where they can control down to the very minute pieces of the virus to make sure that it binds in the right spot.
And that goes to now also to talking about something specific on that, is that the Omicron specific vaccine that's being worked on right now. Can you talk about that? I know Pfizer's working on that as well, and Pfizer works closely with UTB on an actual specific to Omicron. How is that done? And if someone hasn't had this, do they have to go now and get a booster or something like that once this rolls out? I know the testing is going on right now under the development right now.
Yeah, we don't know what that specific is going to look like yet, but this is a vaccine that's been designed specifically against Omicron. And you think about it, it's just amazing. It was we've only known about Omicron since November, like 16th, 17th, and already they're testing it. They're starting the trials in humans. So a lot of how this will be used depends on the results from these trials. But I suspect what will happen is that once it gets tailored specifically against Omicron, there's going to be a lot of protection. And hopefully, as they tweak the vaccine, they'll do it in a way that retains its retention against the other variants of COVID. So that'll provide broad protection. So what this could mean in the future is that, maybe come March, April, May, we'll all get our Omicron booster. And that'll provide us with a lot of protection to last us for a very long time.
And this goes into the question I know I asked both you and Dr. Patel this last week from Kyle Gamble. Do you foresee more lethal variants coming in the future, or is the lethality of COVID fading for the foreseeable future? I'm asking you to get your crystal ball out, but Omicron was one of those that it snuck up. It came from a country that had a low vaccination rate, but quickly spread across the globe.
There's always the possibility that we will see a much more lethal variant. I suspect that's not going to happen. And the reason why is that with the history of infectious diseases, what we see is that as time goes on, that these, particularly with viruses, that they tend to mutate in ways that make them less lethal over time. And think about it. What's the virus trying to do? It's simply trying to survive. So if it kills off everybody, it's going to die. And the best thing for the virus to do is to be highly transmissible and cause minimal disease. And Omicron is highly transmissible and it's causing less disease. It's not causing minimal disease yet. So my bet is that future variants will not cause as much problems.
And this is a question we get all the time. Jennifer Hubenek asks, "Good afternoon. Do you see any immunity? Do you get any immunity after getting it?"
Oh yeah,
it's Omicron, and that we've seen kind of studies trace, but I guess it looks like it's like a 4 or 5 month type of immunity, or is it that long based on what we're seeing with Omicron so far?
Yeah, so the study just came out recently that says at least 4 months. Okay. And the reason why they say at least 4 months, it hasn't been around that long.
We just hit the 4th month, right?
Right. So it takes a while to follow these out. It's anytime you see a study with this sort of thing, it's only going to be as good as the distance between the start time and the end time. But yes, there is immunity that occurs, and certainly we saw that with the wild type. We saw that with Delta, and we saw that the people that had the best immunity were people that had previously had COVID who had gotten vaccinated. And then what happens? Omicron comes around and all those people are calling me up going, "Hey, I just got this virus. You told me it wasn't supposed to happen." And I'm going, "Well, it wasn't supposed to, but the virus keeps humbling us and changing the rules." And so, that's why we see that happening. But even in those people that are quote unquote highly immune, when they got Omicron, they told me that they felt bad, but only for a few days, and it went away very quickly for the most part.
And this brings up Latanya Nunn, who says, "I've had it twice in 5 months."
Yep.
That's not unusual with Omicron, right? That's what we're talking about, the infectiousness rate of this.
Yeah,
is that
more and more
several folks have it more than once within a short period of time.
Yeah, more and more people are telling me that.
We didn't see that so much with Delta. Why is that, you think?
Because Omicron's more infectious, and Omicron does evade the immune system and then the immune response. So remember that if you get a vaccine, that those antibodies are specific to that vaccine. And if you get an infection, the antibodies are specific to that particular infection. And so now you've got something that kind of slips into the crack. And so it's not enough immunity to keep people from getting infected, but there is enough immunity to keep people from getting really sick from it. That's the state where we are.
And we should point out, Latanya came back and said she was fully vaccinated and had her booster, and this happened.
I believe you.
Curious to know how ill you were with that too, because that's been one of the things I think we've been trying to follow up on with many folks, of that there seems to be at least some help where, you feel like crud, but it's not as bad as if you were unvaccinated, at least for the determination based on what we're seeing numbers wise coming out there. Right.
And we can bear that out with the looking at the numbers of people that have breakthroughs. We've had almost 8,000 breakthroughs, but we've only had a few hundred who have been hospitalized, and we've only had 50 deaths out of 600 deaths. And so again, most people that get in the hospital are not vaccinated. Most people who die are not vaccinated.
Right, and that's the in particularly too, as I said, we get the stats every single day, well, except for Sundays, but every single day. And if you take a look at those numbers, and there's a breakdown, and we'll do that on the next show too, is that we actually have a breakdown that can show. There's a chart there. It says unvaccinated, vaccinated with booster, vaccinated had COVID, and there's an actual breakdown of that to show that along the line. So we'll and Latanya did answer respect. She says it was like a bad cold, definitely better than the first time around. So we're good to hear that. We're good to hear that for you, Latanya. Hopefully you're on out there. And here's a question I get all the time from folks: which vaccine is allowing more breakthroughs?
Okay, so the best guess is that Moderna is probably the best, with Pfizer running a very close second and the Johnson & Johnson running third.
When you say the best, meaning that more effective?
most effective, right?
of getting
With the
of
least
having a breakthrough.
breakthroughs, right? But the difference between Pfizer and Moderna is not even within the margin of error. So if it were an election, you would say it was too close to call.
Yeah, well, it's one of those. I get both. I had both in my system, so that my booster is Moderna and the other were Pfizer. But it did come up. We did have a question. A lady had asked. She said she had her booster in August. Does she need another one now? This is another conversation we had last week, and at this point, the actual recommendation is no.
The current recommendation in the United States is no. In Israel, they are boosting people that are over 65, but some of the early data suggests that that fourth shot doesn't give you that much more protection. So right now, quite frankly, it's probably not needed unless you're someone who falls in that category of people that don't make antibodies, and in which case that wouldn't be the way we would go with you. We wouldn't give you another booster. We would give you the antibody infusion that keeps you from getting COVID.
Let me ask you this though, as well, is that there's been a lot of talk here, really in the last several months, of focus on therapies, focus on treatments, like with flu. That there is yes, there's always a push to get the vaccine, you get your flu shot, your flu vaccine, but then it comes down to is all right. Once you get the flu, everyone knows they can go in and they can get Theraflu or something like that, not Theraflu, Tamiflu, and get it prescribed, and they feel a little bit better, and they write it out and do that. How close are we to having a treatment? Therapy, treatment, whatever you want to call it, that becomes a regular routine for this?
We are very close, although the question is can you actually get it? So the Paxlovid is available, and as is Merck's product. It was available in very small amounts in December. I think Texas only got 4,000 doses, which is probably enough pills for about 400 people. The second allocation, which came this month, was about 40,000 doses. And the real question is that can your doctor get it for you? And so I'm actually looking on the Walmart site right now, and I'm typing in my zip code to see if I can get it. 77554, and yes, it's available in 6 stores in Galveston right now. So basically, what the recommendation is that if you have COVID, you can only get this medication by prescription. It is recommended for people that are at higher risk. So if you're feeling sick and you think you have COVID, or you have a test and you test positive, call your doctor. And then what your doctor should do is make an evaluation as to whether you need these medications or not. And then he'll call in a prescription to either Walmart or CVS, one of the pharmacies that they know have it, so that you can get it. We don't know how quickly those things are going to go. The other problem with the medications, if I may refer to them as problems, is that you do really need to go to your doctor, because some of these medications cause interactions with other drugs that people are on. And so it's not for everybody. And it really has to be tailored to the specifics of your need for treatment, as well as what your underlying health conditions are and what other medications you're on.
And this will be the wild question of this, that pricing was an issue on that as well. Right now, insurance has to pay for it.
That's right.
But at some point, somewhere, that restriction is going to get somewhat lifted. I say somewhat. It's going to happen quietly. We're not going to know about it.
Right.
And again, and so and if I could have you also repeat the name of the meds. Latanya was asking us. Latanya's still not feeling good, so we could try to get her some meds right
one
now.
is called Paxlovid, P-A-X. Let me spell it right, because I'm a terrible speller. Let's see what actually they're saying. So one's called Paxlovid, Paxlovid, and the other was called Molnupiravir. But looking at the Walmart website right now, they don't say which ones they have at each one. So again, this will be something, whether you get these drugs or not, really depends on on what your underlying medical condition is, what medications you take, because there's some meds you can take one drug with, some meds you can't take the other drug with. And so that'll be a decision between you and your doctor. And then the doctor is going to have to call the pharmacies to see whether they want to have those medications available.
And it may be easier to Latanya, anyone else listening to it, ask for either Merck or Pfizer.
Yep.
COVID pill. That's probably the easier way. Those are the names we do remember, because I can never remember the names either. And so, Latanya, I hope you're feeling better, and you get to and you talk to your doctor and help you out there. And it does go to Beth McGinnis, who just said, "Can we stop pushing the vaccine?" She believes in it, but just not for the whole population, and boost their immune system. We're hearing more and more about that. We were hearing this early on. Hey, just boost your immune system. I think we should point out that's what the vaccines do. They help your immune system fight off the infection. So that's the start. But I understand the sentiment here, which is what can some folks do? This kind of goes to what we were talking about before. It's the normal stuff. Stay hydrated, take your vitamins, eat well, and if you do that, you do help your immune system. It's beyond that becomes the trick, does it not?
Yeah. And so, I mean, probably the most important thing is be healthy. And, that's one of the things I think we've learned with this is that people that are healthy, it's very, very unusual to have a bad outcome with COVID. I mean, it happens every now and then. And we've all heard these horror stories of, healthy 25-year-old. But for the most part, that's not what happens. So be healthy and get lots of sleep, take vitamins, do all the things that you learned to do in kindergarten to take good care of yourself. And then the other thing is that if you're worried about getting it, or if you're worried about your child or other members of your family, do the responsible thing and avoid the situations where you might get it and bring it home.
Yeah, you talk about the things we learned as a child. Sitting down, going through some of my research today, getting ready for today's show, I came across a meme that I've seen thousands of times. I think it's still one of the funniest. Who would ever thought the game of keep away cooties would become a lifestyle much later? And it's true. I mean, the whole thing of staying away from folks and so you don't get cooties from someone in your classroom becomes somewhat of what we're doing now, which is don't shake my hand, don't.
Don't wipe your nose on your classmate, Well,
it's the one, I will say this is the one thing. I mean, you and I talked about this the early days when we were first doing these weekly shows. We were in person all the time. Should point out, Dr. Keiser and I see each other out and about in the public all the time, actually. But we do these remotely because it just helps us out. It's a lot easier. We're not doing this any longer just because we want to stay away from one another. It's just that he has his office, I have my work. We can get someplace and do this. So that's the main reason. But, the early days of touching our noses, we had people always teasing us how many times they'd catch one of us touching our face or something like that in the early days. I think now we go, it's almost like don't blink. It's like we go the whole show and we don't actually reach up just out of consciousness.
You're making my nose itch. Right
I know,
now.
right? Just talking about it. Right. And so, and going along those lines, one of the things I want to ask you about too is, is flu and pneumonia at this point. Yeah. Obviously, that's always a concern. Is that what are we going to see on flu? What are we seeing right now? Flu and pneumonia as well, because we're in the heart of flu season, but now we're also getting into that time of the year where pneumonia becomes a big issue. Normally, now we're in COVID era. There's pneumonia, but it's COVID related that we're seeing it now.
Right. So fortunately, we follow the flu cases and the cases of other types of pneumonia, and then there's also the concern, and we haven't seen that much flu. That's the first thing, we really have been looking for those cases of flu and Omicron, and again, we've had a few, but not very many. So there was a lot of worry about that. What happens if we get a lot of people who are getting both of them? And it just doesn't seem to be happening at this point. We are seeing a lot of other viruses, though. And so when people are going out and getting tested, and they think, oh, I must have COVID, and their test is negative, and then they go get tested again, and then they get a negative test, and then they go get tested again, and so you probably don't have to do that. So if it's negative, it's probably something else, because we are seeing other viruses is out there. So there's an odd phenomenon that comes with viral infections in the winter, is that if you have one major virus circulating, that tends to be the dominant one, and it drives out the other viruses. And so that's the situation we're in right now. With all the COVID, we're not seeing a lot of other infections at this point.
And then you talked about we're seeing some other things. You're talking about too. One of the things we're kind of seeing is these kind of it's bacteria that's resistant to the meds. Can you talk about that some too?
Yeah, no, I think
every once in a while we hear about that popping up.
Right, and so the World Health Organization has recently said that this is going to be a big issue, and CDC, in terms of their planning for the future, they're also concerned about this. And I can tell you, from what we see at UTMB, we've seen the numbers of these superbugs go up and up and up every year, and so we see the ones that are just resistant to everything, and that's still a minority of cases. But in the past, if we would have one, it would be shocking. And now it's almost become routine, and we have our protocols which we use to handle it. But we're also seeing these intermediately resistant bugs come up, and so these are variants, if we can use that terminology, of normal bacteria which are gradually becoming resistant. And the concern is, if this keeps on going long enough, we're not going to have good antibiotics to treat people. And so part of the reason why we're seeing the rise of all of these is because people go to their doctor, and you have a virus, and I've got COVID. Well, doc, can I have some Augmentin? Because usually Augmentin helps me. No, Augmentin's not going to help you because it's COVID. And but whenever I get a runny nose, I take Augmentin. And it's that kind of overprescription of antibiotics. And so we're working with a lot of our outpatient doctors to try and avoid doing that, to make sure that you get a strep test before we treat you for strep throat. And we're also, the other thing we're seeing, and we're seeing this actually being driven by COVID, is people come in the hospital, they're really sick with COVID. And so their doctors will just throw the kitchen sink at them with antibiotics. I get it. All right, I'd probably do the same thing. But when we know it's COVID and not something else, then people are afraid to stop it. And so people just get overexposed to all these antibiotics, and they stop working as well. So I think COVID's made that worse. And I think that as we see, as we move into either, post-COVID or COVID, becoming endemic, I think we're going to see a lot more emphasis on wise use of antibiotics.
And what makes something from a pandemic to an endemic? Where do we know we've hit that point? I know we talked about that last week, but I wanted to clarify that to folks.
Yeah, when it reaches some stable, predictable levels and patterns, one could make the argument with 2 Christmases underneath of us that we've already figured that out, right? Over Christmas, you see a lot, but I don't think that we would consider having 10% of the population at any one time infected with this virus as being an endemic type thing. So, a few percent of people, it's always kind of there. It may have seasonal variation. We certainly see this with influenza. We have typhus in Galveston, which is an infection that they saw in World War I, and also in World War II. But it's here, and we see it. We see seasonal variation. It goes up and down. So that's when I think it becomes endemic.
Beth McGinnis has another one here. Are we close to herd immunity? We heard there was a lot of talk about herd immunity, and we had to get to that 70% and everything else. Is that definition changed some, or is herd immunity not even really a part of the conversation any longer?
Yeah, it hasn't been part of the conversation particularly. I mean, Delta put a big kick into the idea of herd immunity, and then I think with Omicron, who knows? We'll see. We'll see what happens. But the idea is that how transmissible is the virus, and so for a virus like measles, which is one of the most infectious viruses that we know of, you need to have like 95, 96% of the population vaccinated to keep it from spreading. And we've reached that in the United States. And so, occasionally you'll see these outbreaks of measles among unvaccinated kids, but usually those are very small clusters and they don't spread very far with that. So initially, when we saw the first Omicron cases, we were thinking that maybe 70% of the people with immunity would be sufficient. Well, that's clearly not the case. We have 7% of our population vaccinated, right? And when you add in the number of people who've gotten infected, we're above that. And then when Delta came out, it was thought maybe it'll go up to 80%. And now when I talk to the virologists, they're not very optimistic that we will ever reach true herd immunity, that it'll probably, because we'll probably be like measles, where we would need 97, 98% of the people vaccinated. And we have to have a really good vaccine that doesn't wane over time. And unfortunately, we're not there yet.
The other thing that's come up, we talked about this last week as well. I know there's a lot of topics we talked about last week, but I wanted to revisit them here today. I'm calling them the pop-up testing sites.
Yeah.
We've hit a wall in vaccinations.
Yeah.
Testing has gone way up at this point. Now, and I should point out, a lot of times I'll get hit up by a group that says, hey, because the county can't do any tests and stuff like that. I don't think y'all have had any problem filling appointments. I don't think you've turned anyone away at the health district, right?
No, in fact, we haven't. In fact, we've been doing drive-through testing for the past 2 weeks, and we're going to shut it down at the end of this week because we're not getting enough people to justify doing it. We were set up where we could do up to 1,000 people a day. I think the most we ever had was several hundred, and this week that number has dropped down even more. So we're going to continue to do that, and probably tomorrow we'll make a decision as to whether we stop it at the end of the week. But UTMB, the demand for testing has gone down, and then there's testing all over the county. You'll see these drive-through testing places, some of them done by very reputable people, some not. I saw one in a gas station.
Yeah.
And I was in Lamarck, and I think the Urban the Urban League had a small testing spot out there. So the tests are getting more available. And one of the big things that's happened last week is that the post office said that they're going to start mailing it out. And so everybody, as soon as we heard that, everybody, the health department signed up to get their free test from the federal government. And a couple people got notifications that they're going to get theirs this week. So we'll see, if they come through. But eventually, there's going to be enough tests that anybody wants a test is not going to have a problem getting it.
Here's one that is a good one to ask: is how bad do you think the healthcare worker shortage will be after the CMS rule? I guess this is because based on the court decision, Supreme Court goes into effect, and there is a shortage. There's no doubt about it. Burnout has hit big time with healthcare workers. Nurses have options to go across the country, higher pay, because they're kind of these influxes. One of the things in our conversation last week, we talked about UTMB specific, but overall, what are you hearing from talking to HCA and Methodist and the hospitals in our region? How are they holding up? Texas Medical Center, how are they holding up as far as staffing? Because the number of physical beds is not the issue to be talking about. It is you have to have those beds staffed for sick people. How serious should we be taking this, and is it going to get worse once everyone has to be vaccinated who works in a medical setting?
Yeah, I suspect not. I think there are a bunch of issues there. There's first of all, there's people getting burned out and they're just quitting. And I get that. And we have people here that just get tired and they want to go on to something else. And then on top of it, we faced a big problem over the holidays because Omicron was just sweeping through, and it was an issue of not having people were out because they were sick, and people were out because they had COVID. And so what we've seen is that a lot of those folks are now coming back to work. So the staffing levels are coming back up. In terms of people not wanting or the CMS requirement to get vaccinated, there was I'm trying to remember who published it, probably in November, a listing of every place that put in a vaccine mandate. and how many people got laid off, and then how many people actually got fired. And it turns out that it's about 1% of your workforce will actually say, no, I don't want to get vaccinated. And then when they get told that they're going to be suspended, about half of them turn around and do get vaccinated. But for what we've done here at the Health District and Coastal Health and Wellness, we've asked everybody, give us your vaccine status, and then have been able to work with people, either getting them vaccinated, getting them an exemption, either a religious exemption or a physical exemption, and we're at 100% compliance at this point. And so I know UTMB had kind of put things on the side for that, and I think different organizations have handled it differently. But at the end of the day, my gut feeling is that except for those people who want to make an issue of it and protest, that for the most part, employers are not looking for a fight. They want to try and accommodate people as much as possible. We need everybody, and maybe it's the issue is that okay, right, you've got an exemption and you have a health condition, so maybe you shouldn't be in the ICU. Maybe we should find another place for you to work. You know what I mean? And so I think there's a lot of accommodation that can be made.
And one of the things too that I've seen kind of come up on kind of approaching this has been some kind of reassignments of folks if they didn't need to be in a specific medical setting, if they weren't vaccinated. There's been ways to kind of move folks around and do that. And I think that was one of the things I know Dr. Ben Raymer talked about. They're looking at all type of options, what to do, not hey, where everyone's let go that doesn't do this. Right. Although it's still a high percentage of the healthcare staff. But it's pretty clear from the Supreme Court ruling, and I should point out, this is not a political part of the argument here, but Supreme Court rulings, there seems to be this differential between saying medical people need to follow different sets of rules than folks in the regular workforce. Right. And I think that's going to be the biggest stark contrast.
But I think that makes sense, right? I mean, it's and they're having the same issue with the military, and the military's argument is that they need it for force readiness. And for we as healthcare workers, we signed up for this, and in many ways we put ourselves, our health at risk, and by the hours that we keep, and the stress of the job, but also well, the other thing we signed up for is that when people get sick, we're going to take care of them, even when they have contagious diseases, and we're going to do the best we can to protect ourselves. But we're not going to walk out of the room and leave you there. And so part of that is part of the bargain that was made when we signed up. So the Supreme Court has said for certain groups of people it's reasonable to do that, and for others not so much. It's an overstepping. And I think that's what we're seeing going on in the courts right now. That they've kind of carved out healthcare workers, and now the question is how far can this extend? And does it extend to federal workers? Does it extend to OSHA? Does it extend to the military? And all of these various things, and that'll be up to the courts.
And it gets into as well that something I think we've talked about from the get-go on this is that you don't want to have a healthcare worker who's sick around you or potentially sick at the same time, but you've got to deal with those sensitivities too. You can't just treat them as humans, but they do have a different standard than say a journalist, for example. And I should point out we have a mandate in our company. I've brought this up several times that we do, but those who don't want to be vaccinated don't work in the field. We've made accommodations for that. It's not hey, you're out of here type thing. Right. Yeah. But that's just one of the requirements we have because we deal with so many people, and the idea is we don't want not only them to get sick, we don't want other people to get sick. And it doesn't stop things, but it does have that. So anyway, that's that conversation there. Let us know what happens on the testing. I mentioned that there's some pop-up testing sites there. We did Isaac Saldana, the Kemah City councilman, has worked with a group over there. This is not a city thing. It's just a private firm. They've set up next to Crazy Island Swamp Shack, 500 Texas Avenue there, and they're doing testing and have plenty of room if you do want to go over to check it out. and do that. They say it's absolutely free. Let us know if it's not. If someone is not being honest there. And just as we saw with a group in Texas City, they weren't wearing gloves, weren't following certain procedures, and the like. Call the health district if you see them not following that.
Yep.
Get a visit.
We're going to check them out.
Yeah, and
we'll go stand in line and see how they're doing. That's basically
how they're doing on that. But yeah, if you want to go over to Kemah, 500 Texas Avenue, next to Allen's Swamp Shack, there. So I guess you can get tested and go get some crawfish afterwards. Although they're kind of small, if you ask me. Right, that's just my personal crawfish preference right now in January. Wait until a little bit, next month we'll be okay. Any case, but in any case, you can do that. Check it out. Dr. Philip Keiser, local health authority for Galveston County, and as well as the CEO of the Galveston County Health District. Thanks for being on with us. We appreciate you, sir, and we'll talk to you again next week. Again, join us each week here. We're going to try to get this back on a regular basis. And as I keep promising, we are going to talk about something other than COVID at some point, but this is the dominant.
I hope so. I'm getting tired of it.
One of the things we will be touching on next week is to talk about do not be skipping your mammograms. Do not be skipping your cancer screenings. Do not skip all those other things that are there available for you, because I got griped at by one of my physicians the other day because I missed out on an appointment. I actually totally forgot it. It wasn't because of this, but they said they're so crowded with everything else right now that those actually kind of tail them back a little bit more. So make sure you're making those appointments for your other things. We're going to talk about more about that as well there. So you've been watching What You Need to Know. Thanks to Dr. Philip Keiser for us. We'll talk to you next week.